In ulcerative colitis, we know that diagnosis include both the extent of the disease, as well as requires doing endoscopy, as well as pathology to show that the patient already have ulcerative colitis. And now there is a trend to differentiate between activity and severity. And activity means that what is the patient having now? So what is doing right away, but severity means the history of the patient. How severe, how he's doing for the last few months since diagnosis, few years since diagnosis, till we have him now. Then we will go for induction of response and maintenance therapy followed after. So what we are doing that we need the activity. This is the burden of inflammation right away. Severity is the disease phenotype and scores, and this is helpful in determining the prognosis and predicting the complications. So activity has been true and love, as you can see here. It has been added now to the new ACG index of activity, and that shows that in addition to the stools, blood in stool, the urgency, the hemoglobin, the anemia, ESR, CRP, as well as free calprotectin has been introduced, and endoscopy, both Mayo score and UCIS, all have been now included to differentiate between mild and moderate and severe. So activity now it can be graded, and this is the last publication from the AGA last month. They are showing what is the disease severity variables in Crohn's as well as in ulcerative. So in ulcerative colitis, it is, as you can see, young age, as well as the extensive involvement, as well as emergency, emergent diagnosis, hospitalization, as you can see in here. And this column is showing the disease activity variables we already talked about. So you can now put activity and severity and put the patient whether they are in high risk or low risk. And this is the strive to calling what are the high risk, young age, extensive colitis, frequent relapse. And now a flow chart has been introduced that putting that patient with low severity and activity, mild activity, it will be mild, low, moderate and severe, it will be moderate, and high will be mild will be moderate, high, moderate or severe will be severe. That means that past is the severity and history, present is the activity now, and this is the future, what we expect in the prognosis of our patients. And so the stride, tell us again, stride today, is that in the active disease, you stratify your patient. So according to risk, and then you will start to give the medications, your medications, whether mild, moderate or severe, according to the severity of your patients, as well as activity of your patients, and whether it is risky or not. So activity, severity, risk, and then try to put your medication and then follow up short-term, intermediate, as well as long-term. And the target in ulcerative colitis has been moved with time. So it will be now the Mayo underscore subscore 0 or 1 plus histology, Nancy index, as well as or Roberts index, though are there now competing who will be the better. New UC endpoint has been used in Unify. It's a histoendoscopic mucosal healing, and now in all new drugs, now we put it as a new secondary, as you have seen publication, the presentation of Dr. Silvio and the others, Vanisi, they are saying now it is now in the all new drugs, the histoendoscopic index is the target. So what we have for having these targets in our hands. So we have the immune modification and suppression, 5-FCA, steroids, thiopurine, anti-TNF, anti-integrins, anti-IL-12, IL-23, and JAK, as well as the microbiota manipulation, we hear about it today, as well as surgery. And this is the treatment option we have in ulcerative colitis. You can have JAK inhibitors, as well as the other anti-TNF, anti-ustekinumab, which is said anti-P40 because this is the link between 12 and IL-12 and 23, anti-integrins and immunosuppression. So we have to a case, we'll have what to do with this case. This is a 19-year-old female, old male, known to have ulcerative colitis since the age of 13, presents with refractory ulcerative colitis over years. So he has ulcerative colitis, and this is the endoscopy here. Moderate activity, hemoglobin 9, CRP 19, calprotectin 300, and the endoscopy Mayo score is 3, and extension is beyond the hepatic flexure. So it is extensive, Mayo score 3, moderate activity. So this patient has been treated with 5-SA with a dose of 4 grams per day daily, according to the momentum trial that we can use 5-SA in the beginning. Was that the right choice or not? We will go to the AGA clinical pathway risk. This patient who's having low collective risk, you give 5-SA, rectal SA, with oral budesonide or oral corticosteroids and/or rectal steroids. If they go to remission, you can maintain and then taper steroids. And if not, you will go for high corectomy risk. So for this patient, we should not maintain him on 5-SA alone for how many duration of time, a long time, without trying to have rectal as well, or boosting with corticosteroids or rectal steroids. And then go for so this patient, but if he is mild, 5-SA alone could have been oral or not oral, it will be okay. But if it is not, we can, as we said, go with some steroids, booster steroids with it in sometimes trying to boost our treatment. So our patient never achieved good response with the 4 grams per day daily. What would be our plan now, and what is our target now? Again, this is the evolving management approaches now, is that to manage our patients, we need to have first predict the disease course and response. So that means that risk stratification of our patient, and then assess the treatment target, and then put a treatment algorithm. And number 4, monitoring algorithm that the patient is okay. So this is our management approach to all IBD patients now. And STRIDE, as we said, is saying, so applying this to our patients, activity, mild to moderate now, it is almost moderate. Severity was low, stratification is high. So the patient have high risk, severity may be low or to moderate, and here activity now is moderate. So the patient, according to this, last month's AGA approach is saying that we should go for, if it is moderate, we'll go for 5-SA plus corticosteroids, or go for either immunosuppressive, biologic combo, or go for vidofludimus or ustekinumab plus or minus thiopurine. This is the options we have, and this is what is written in AGA. So if the patient is high risk, is the same, and we are going for anti-TNF combo because, or vido, or ustekinumab, or tofacitinib. How we can positioning, it depends what the patient is having. We will pick the answer, we pick the right choice. If the patient have extensive external manifestation, so TNF will be the answer. If the patient have a sort of convenience and traveling a lot, or has not limited access to the medical time. So you can go for something subcutaneous, so ustekinumab or adalimumab, because it is subcutaneous. If above 65, so it will Vido or ustekinumab. History of lymphoma or melanoma, so Vido or ustekinumab. Rheumatoid arthritis, TNF or TOFA. Psoriasis, TNF or ustekinumab. Then if the patient already have partial or no response, then you shift to either TOFA or ustekinumab or vidozulumab. And if non-response due to anti-drug antibodies, so you have the same thing, go out of class and give TOFA or vidozulumab or tofacitinib. And AGA is telling that. So telling us that if you start to early use biologics, and then for biologic naive, start with TNF or Vido, and TNF is preferred over Vido preferred over adalimumab based on relative efficacy on ulcerative colitis. This is the varsity study, and TNF if better than adalimumab in also other studies. Ustekinumab was not put because AGA was done before its release, and TOFA is effective and we approve as a second in not in TNF naive, but in TNF failure. And this is for our patient. 5-SA was discontinued, and the patient was put on infliximab combo therapy, infliximab azathioprine, and this is all the results that TNF immunocombo therapy is good in patients in such a situation. And this is the success using combo. This is success trial saying that azathioprine infliximab as in patients combo better than monotherapy. So the patient was put in infliximab and lost response after 18 months of treatment, and a trough level was done of 6. If you can see here, infliximab should be around 5. So it is sufficient, but start to have high antibodies. So the patient have a sort of secondary failure to infliximab. Currently, hemoglobin 9, CRP is high, calprotectin is high. What you should be next doing in this patient, when our patient have a sort of secondary loss of response to infliximab. And this is the flow showing what we do in patient of infliximab loss of response. It depends on if we have low trough levels or high trough levels. First, try to optimize the treatment. And if it is not having antibodies, so you should change your mode of decision. And having as SCDM means shared decision making between you and the patient and patient family, as well as the surgeon, because the patient could prefer to go for surgery at that time. So, but the AGA put the second possibility that if you have failure of this scenario, you will go for either ustekinumab or tofacitinib. So, usually, TNF failure, ustekinumab, tofacitinib for ulcerative colitis, and for Crohn's disease, ustekinumab. Decision making, which is better, advantages of both and disadvantage. Advantage of TOFA, it is fast onset response, oral administration, rapid absorption, short serum half-life, and no immunogenicity. And advantages of, while the disadvantages that it increases risk of infection, and need for regular laboratory monitoring for especially lipids, and not yet defined response, especially for the cardiovascular profile, pulmonary embolism and others. Currently not recommended during pregnancy or breastfeeding. The advantage of ustekinumab is that excellent safety, of course, but the advantage is that is slower response. It has intravenous and then subcutaneous. And of course, there is a risk of potential antibody development, but it is low, but it is there. And of course, long half-life. So what is the JAK inhibitor activity? That tofacitinib is one of them. Tofacitinib is one of the class that it is non-selective JAK inhibitor, and we heard now some papers about others for filgotinib as well as upadacitinib in the last echo with good response to ulcerative colitis and Crohn's disease. And this is the OCTAVE study that proved the efficacy of tofacitinib in ulcerative colitis that get the approval from FDA for using in ulcerative colitis because of this study, that about 40–60% of patients already have TNF inhibitor experience. That means they are failed to biofailure, experience a response to tofacitinib. And this is the last one of the last papers in the last few months for occurred on tofacitinib, showing efficacy of ulcerative colitis, and a patient up to 52 weeks with good safety. This is safety and efficacy, as well as this is extended trial has been extended with no side effects for years now. And this is the efficacy for extended duration. This is, we tried to put a sort of the patient who did not respond to 5 milligram BID, which is the standard dose, to make it 10 milligram BID and extended for more time. And they proved by the end of this study that the double dose, which is 10 milligram BID, successfully saved some few more people that they were not responding to the initial standard dose. What is more recent, it has been published last week, is that the use of tofacitinib in the biologic experienced hospitalized patients with acute severe colitis that already failed the biologic, and this patient would have been gone to surgery right away. And the use here, this is the use of tofacitinib 10 milligram TID, and they successfully 70% were saved from going to colectomy and with no severe side effects. So tofacitinib has been used for many years now, and but to have a sort of with the risk of increase a little bit of herpes zoster, and but no deaths or perforations or changes in some changes in lipids as well as CK. And this is last month as well, the real world tofacitinib cohort of patients with on patient with ulcerative colitis, and it didn't change much, that we have a sort of a high success rate, 90% induction, 85 maintenance, and they have a sort of in a lot of patients here, 260, around 15 serious side effects and 12 patients discontinued, but a 10 milligrams, 5 herpes zoster and 2 having DVT. So there is some risk here, but it is small. So our patient, after taking medications, the tofacitinib twice a day for 2 months, then the patient was asymptomatic, the diarrhea stopped and bleeding stopped and pain stopped, and the hemoglobin was 11, CRP is around 3, and calprotectin is around 100. And this is the endoscopy showing Mayo subscore of 1 and UCIS 2. That means it is almost healing. And what to do next? To do next, that we should achieve our target. So every 3–6 months, at least for the first year, clinical visit and inflammatory markers, calprotectin and CRP. Every 6 months, intestinal ultrasound or MRI, and every 1 year endoscopy till we reach our target, which is the histology in ulcerative colitis, trying to have mucosal healing. But if you reach the histologic index, it will be best. Thank you very much.